Okay, I think I finally got it. Holy smokes. Here we go, here we go. Alrighty, I think we are back in action here. So thank you so much. If you watch this live, thank you. The sound didn't carry over again, and that was the issue we were having the time before. So I got a little bit of help, and I think we finally got it. So let's hope that this is it. Okay. So round two of round three of Pelvic Grand Rounds. It's been a little bit wild, but welcome again to Pelvic EDU, the Pelvic Grand Rounds series. We've got Is It Ortho or Pelvic round three. So we will be covering when mid-thoracic pain isn't necessarily a vertebral issue, okay? And the reason why I'm covering this is because there is a little bit sometimes of like overlap or even some confusion when it comes to patients describing where they are feeling their pain. And often what we get in the clinic, after patients go see their doctor, their physician, whoever it is that's referring them over, they come in with a script for, low back pain, evaluate and treat. And then we start digging a little bit, and sometimes it is very apparent that we may not have just a purely orthopedic issue going on. Nothing's purely anything, honestly. It's not purely an orthopedic issue, a neurological issue. We are a body with multiple systems, and all those systems are going to have some shared inputs or some shared conditions or just a little bit of confusion in terms of what the patient, like I said, may be describing, and you have to peel the layers. So this is one that is definitely going to have some layers that we need to peel. Excuse me, I apologize. I've been drinking a lot of coffee, and I sometimes get a scratchy throat. So anyway, let's go ahead and get started. All right, so common thoracic conditions that we see are related to like arthritis. Okay, so OA at the thoracic spine, and this may be coming from, issues related to posture. We see that a lot, especially maybe as we're getting older, our posture starts to suffer because of weakness, just kind of globally. The abdominals obviously have a big part in how our posture does overall, but other weaknesses like at the paravertebral muscles will absolutely give us that kind of like slouched, bent over, kind of stooped position. And you'll start noticing people complaining of pain, just kind of like that mid-thoracic, lower thoracic area, and definitely around like the shoulder blades. They point at like the rhomboids and that sort of thing because things are pretty uncomfortable for them. So we see the, conditions related, like I said, to muscle weakness. Sometimes it's more of a like shoulder perhaps condition where they've had some shoulder injuries, or they've been having some shoulder stuff going on for a while. And so they start describing some kind of discomfort right in that middle thoracic spine, even upper thoracic spine, of course. And so we have to take a look at like the rhomboids, the middle traps, see what the strength is like for those. And of course, anteriorly at the pectorals as well. And then looking for what could be causing maybe some of that pain coming from the nerves. So you're looking at some of like the stuff that's innervated by the long thoracic, and you want to ensure that maybe it isn't coming from a little bit higher up in the spine as well. I already mentioned poor posture, but because it is, a pelvic ground rounds, pregnancy also is a condition. It is a state of being that could be causing some thoracic spine pain. Okay, so the thoracic spine is one of those areas where you will get also some referred discomfort or pain coming from other areas in the body. And so you have to be very cognizant, you have to be aware, you have to remember all of those referral patterns as well, because you don't want to be chasing your tail, and you don't want your doctor to be chasing your tail, and you don't want the patient to say, I went to my doctor, I went to PT, we did all of this stuff, and it turned out that it was actually a kidney issue, a liver issue, a gallbladder issue. And so those areas can also refer pain to the thoracic area in general. The kidney, of course, could be right or left, so you have to think about that like middle to lower back of that thoracic area where you may be having that discomfort. The liver on the right side is absolutely going to give you some referred pain up to the shoulder even, as would the gallbladder, okay? And this is where having a good intake is also going to be helpful. So asking things about like the GI, are you having some nausea, vomiting, some severe pain that doesn't even go away when you are lying down, when you are resting? Is it, what kind of provokes it, and what is the frequency with which they're having that pain? So if you are thorough in your exam, you will be able to save people just some wasted time and get them the, of course, proper care. But another visceral component that refers pain over to the thoracic spine is the diaphragm. And this is where we're going to be spending a good portion of our time today, because the diaphragm has so many different attachments into that thoracic area and the rib cage in general, that you have to, you can't ignore it. Okay. So when people are coming to you with, that, diffuse kind of like pain in the back, don't hesitate. Don't, wait to also just kind of clear that diaphragm. And it's pretty fast, and I'll show you how to do it in a moment. But here are the attachments. You've got, of course, the rib component, which is like 7 to 12 ribs, the lumbar spine, the medial part of the L1 through 3 body, intervertebral discs as well, okay, anterior longitudinal ligament, right and left crura, the lateral part, you get those arcuate ligaments, sternal part as well, you get the xiphoid process. And so you've got the insertion and the innervation, you got the phrenic nerve, C3, 4, 5, keeps the diaphragm alive, which is something that we need to keep in mind when we are also dealing with shoulder pain, because as you remember, and as it's been driven into our brain, the cervical innervations 3, 4, 5 are kind of this general shoulder area as well. So you have to be also aware of the diaphragm when you are looking at the shoulder, okay? And then you've got the sensory fibers here as well. So the reason why I'm putting these referrals here is because there's a lot of shared space, of course, okay? And it doesn't take a ton of time to check that diaphragm and be able to just kind of quickly tell whether or not you're having some pain coming from there, okay? So the diaphragm, and I always double check to make sure that I spelled that right. There's a lot of things that I'm like, does that have one, where does the G go? And then trigger, is it 1G, 2Gs, 3Gs? And I write this pretty loosely, trigger points, okay? These are just points in our soft tissue where you are going to experience some, referred pain because there is a tender spot in that area, okay? So for the diaphragm, if there is something going on, and usually with the diaphragm, what's going on is that there isn't appropriate expansion or appropriate activation or appropriate movement of it because of several conditions. This can include, of course, pregnancy. Your diaphragm is just basically kind of like, it's like when you're trying to push something up on onto the roof. That's what it feels like when you're pregnant. You're like, there's no space there. So, of course, pregnancy is one of them, but anxiety and issues with, like respiratory conditions in general, where we don't have a lot of like maybe rib excursion. We're breathing kind of at top here, using our accessory muscles. And so that diaphragm is just kind of like, not expanding fully. We need it to expand fully so that we can get a good amount of oxygen into our lungs to help our lungs really get nice and inflated. But also when we have proper mobility of those lungs and of that diaphragm, we get all of that CO2 out as well when we exhale. And that is important because CO2 causes anxiety. You get those, I remember the term blue bloaters and all of that, where people were feeling very anxious and stressed because they weren't getting that CO2 out. So for those of you that are treating postpartum gals, or anybody who kind of is already suffering from some stress, anxiety, depression, making sure that you're working on that proper breath in, but also breath out is incredibly, incredibly important to help reduce this vicious cycle. Okay. Pregnancy, the respiratory conditions, anxiety, all of those can contribute to not proper activation or proper movement of that diaphragm. And what that can lead to is maybe not good mobility between where all of those attachments of the diaphragm exist, or where that diaphragm kind of, holds space with other parts of that cavity. Okay. And I sometimes hesitate to say it's like, oh, you've got an adhesion or you've got a whatever at the diaphragm, because I don't know. I don't know if they do have an adhesion there because I can't see it. But tissue that hurts or tissue that's uncomfortable isn't necessarily healthy or isn't necessarily doing what it's supposed to be doing. So if you're on that diaphragm, and like I said, I'll go over how to assess it, and they're getting a response, then we know that there's something going on in that area that needs to be addressed. Okay. So trigger points can lead to discomfort at the shoulder of the side that is affected. Okay. Discomfort at the neck, scalene, sternocleidomastoid, anterior ribs, the costal margin, lower thoracic spine. Okay. So when there is something going on at the diaphragm, we are going to see it at the lower thoracic and that TL junction. And this is where a lot of just people in general, they don't, it's my lower back. Where does my low back end and begin? So there may include anything from like the breast area down as their lower back. Okay, so we need to really differentiate whether is it lumbar or is it more like a TL junction, or is it like truly more thoracic than anything. People don't necessarily know how many segments in our thoracic spine exist or what they're supposed to be called, so they're just going to say it hurts there in that area. Okay. All right. So who's going to be walking through your door that you may need to think about the diaphragm? Like this is when because you may not need to think about the diaphragm with every person. I feel like I do, but you're not me. And you may not be, a pelvic person, pelvic therapist. So things to think about if you are going to be looking at the diaphragm. Okay, so the person that's walking through your door is going to have usually a script that says low back pain, evaluate and treat. So it's going to be kind of diffuse. All right. If when you are treating, or when you are doing your assessment, not treating, but when you're doing your assessment with that brand new person, or maybe it's already an established patient, and they're also saying that they also have shoulder pain, and a lot of people do, but when you check their range of motion, passive range of motion, it's pretty good. Okay, well, maybe there's something else going on. They can be of any age or background. Okay, so it doesn't matter who is walking through your door. We get runners, we get people that are currently pregnant, were recently pregnant, and everything else in between. Okay. But if they also have like a vague explanation of their symptoms of low back pain versus thoracic spine. So let's say you do your pivoms on the lumbar spine, and they're kind of uncomfortable, but they have more discomfort at that lower thoracic, when you're checking the range of motion there, when you're doing your pivoms. So you're like, okay, let's go ahead and maybe think about the the diaphragm. If they have breath holding with movement, and again, this is a lot of people, but that kind of lets you know too that there may be some dysfunction there that we need to take a look at, and that's another point for wanting to check the diaphragm. If they have stiffness at the spine, okay, especially some thoracic rotation that is pretty limited. All right, so that's another point for let's assess the diaphragm. And then extra points if they have shoulder, neck pain, anxiety, and pain starting after having like maybe a cold. All right, the coughing, the pneumonia, I just got through like having some strep, just got COVID again, something. And now they're complaining of back pain. I've had people that even broke their ribs from coughing so much. So if any of these, especially the more you look into it, the more, they're kind of like point, you better look at that diaphragm, okay? And so when you are talking to them, and you probably went through this in like maybe a minute or so when you're talking to them, maybe it's already in your intake as well, like, how their health was doing, how things were, the last few months or whatever. And they may have put down, I suffer from anxiety, I do this, blah, blah. But some additional information that you may want to gather, and this is true of any time that you are kind of looking at that lumbar spine, is asking about pelvic floor symptoms, okay? When, when you're in a more just ortho-based clinic, like outpatient, a lot of therapists I have found kind of skim through or skip through or very quickly ask about pelvic floor symptoms. And in the intake, they may look at it and, the patient checked off no. Often the patient does that because they're like, I've got the normal amount of urinary leakage for my age. Yeah, I've had it, but who doesn't have discomfort? Or what the hell is their business? Whether or not, it's not anything that's perhaps limiting functionally or socially or anything. So they just kind of like blow it off. All right. But you need to dig a little deeper and be knowledgeable in how to explain the reason why you're asking about this. Now, for you, this makes a whole lot of sense to take a look at the diaphragm if they've got that thoracic pain, they've got like difficulty with like breath work, and now they're telling you that they've got pelvic floor symptoms. Well, that means that their canister, their pressure management is off. And so you need to think about those pelvic floor symptoms, number one, and then number two, also address, if you can, that diaphragm that same day. Okay, you're going to assess breathing. I kind of got ahead of that. Assess their breath. Okay, check for that rib expansion. Can they actually take a nice deep breath in? Can they take a full exhale? Can they actually exhale completely? Are they having any pain with deep breathing? Because that may be indicative of there's also some ribby stuff going on. Okay, are they having some compensatory breathing patterns? Like, are they using their accessory muscles a ton? Are their obliques kind of like, when you take a look at their posture, everything externally, which you should be doing when you're assessing lumbar spine, and you're looking at those abs and standing, laying down, how well they're able to turn them on or activate them. Are you seeing a discrepancy in how they're turning on that TRA and those obliques as well? Okay, take a look at that sternocostal angle. Is it like way more than 90 degrees? Sometimes they have like a big rib flare, and you have to definitely address that if they're having low back pain and thoracic spine pain. And if they're describing pain that is felt like almost like a rubber band around the torso. Okay, sometimes people will describe that with like anxiety, with like some stress, but absolutely, if they're saying that they have like that rubber band feeling around the torso area, like lower thoracic spine, upper lumbar spine, you need to assess that diaphragm. Okay, and then if you know how to assess it, and there's a little bit of pressure around that area, and they're like, I don't like that, don't touch that, or holy smokes, something happened, then you're onto something, and you need to be addressing the diaphragm and doing some treatment. Okay, so what to do in terms of treatment. So for the let me see, and I think I need to go forward with this one because I may be off. When you are assessing the diaphragm, um, the assessment and the treatment can be pretty much the same at the same time. Okay. And the way that I like to assess it at the very beginning, like that very first, visit or the second visit, is I want to just be gentle. I want to be non-threatening because it can be very uncomfortable. And some people are ticklish. And if all of these, kind of like, your patient is having all of these feelings, they're going to guard and they're not going to allow you to really assess that tissue properly. Okay. And when you're assessing the diaphragm for any sort of like tenderness, trigger responses, you have to just kind of like be, like I said, gentle. Okay. So the way that I assess it, and I'm going to show you here with Dr. Nenny, is I have them in this supine position, and then I place just kind of like a little bit more of a broad contact with my thumbs. Okay, now she's teeny tiny, so I can just pretty much do it with one hand, but you can do it with two. And you follow basically right at that border of the ribs, going down from like the xiphoid process all the way out. And you start with some not very, very tight pressure, not very, very aggressive pressure. Because again, you don't know if you're going to hit something that is going to cause a trigger response. And what you want to do is kind of almost like you want to scoop underneath those ribs a little bit. Okay, I have everybody in that hook line position to allow for a little bit of like slackening of the tissue. Okay, may even want to put like a towel, like just kind of fold a towel and put it underneath their hips so that they're not kind of like in that anterior pelvic tilt and putting everything in a tensioned position. And you can assess in supine and in sitting, but here I'm only going to show you in supine because we are doing this fast. If you want to go over how to assess in different positions, please send me a message and we can go ahead and try to get together and do that. So anyway, you go under, almost like you're trying to reach under those ribs, and it should only feel to the person as if there is some pressure being applied. Okay. So by pressure, I mean, they feel the weight of your hand, they feel you kind of like bring the tissue under, but it shouldn't be painful if there's nothing going on. Well, it just shouldn't be painful. Okay. If there is like and you can feel it on them. Okay. They start just kind of like, oh, that was something there. Then you're onto something. Okay. It's likely, like I said, a tender point or a trigger point that is going to be causing that discomfort. You follow along. And as you're following along, sometimes you can almost feel like there's some release in that tension. It almost feels like grainy under your fingers, and you can hear it. It's sometimes audible as well. And you go down that area, right side, left side. If there's a positive response, if there is, patient describing some discomfort, then you kind of want to stay in that area there. Okay, so here is the complete video here. It's a short little video. You can kind of just hold the pressure there. Okay. So I'm assessing and I'm holding there. She was describing that she was having some discomfort. So I just held it there. I don't tell anybody to do any deep breathing here because they're going to push you out. So just regular breathing. I go back to where we started and just kind of like hang out there. You can also slacken the tissue, kind of go from the side of the rib and just kind of like slacken that tissue so that you can get under there a little bit better. If they do have a positive response, meaning that it's painful, not that they're having like a great time, like this is a positive thing that I like. No, it's like a positive response in terms of the tissue is uncomfortable, then you can hold that area there and then have them do some lower trunk rotations, wigwags, windshield wipers, whatever it is that you like to call it, either both legs together or one leg at a time as you're holding, so that you can give them some autonomy, you can give them some control over that treatment because it can be a very gnarly feeling. Then you move on to the next area that was really tight as well. Okay. And I do this maybe a few times in each point. I don't stick around for a really long time, especially not the first time, because we do need to work on kind of like desensitizing the tissue. And sometimes it's not in like one visit that you're going to get this. So explain that to them, that you want to kind of work on that you want to ensure that they feel comfortable. But this may be an uncomfortable thing to do. The treatment is sometimes, not pain-free. So explain that to them beforehand, okay? And then you tell them, look, this is for you to control. This is why you're going to be doing your LTRs or your little wigwags or your windshield wipers, so that you can control how far you feel like you want to go. If you feel like you don't want to go that far, that's perfectly fine as well, okay? Of note, they may get a visceral response, okay? And by that, I mean they may get a response from their central nervous system that says, hey, I'm ready to fight or flight right now. That is so uncomfortable. I had this done to me about 8 months after I had my first kiddo. My kid was huge. He was 9 pounds, 6 ounces. And so like there was no space in there. He was just pushing on everything. And afterward, I had a cesarean. So, back pain, hip pain, but also had like shoulder pain. I had like range of motion deficits. I knew what was going on, but I was so not looking forward to having this done because I'm just a big old baby. I can dish it. I cannot take it. I will admit to that. And I was working with several wonderful PTs, one of whom is a great pelvic PT and a good friend of mine. She was ready to dig in there. I was like, oh my God, she's going to get in there. And I already know it's not going to be great. So she works on my right side. It's uncomfortable, but I'm just always uncomfortable. And then she gets to my left side. And to say that I was ready to fight, I wasn't ready to fight. I was ready to like, I'm going to kick you. I had a cold sweat almost right away. I had never really experienced that other than like, I was going through contractions and childbirth and that sort of thing. But otherwise, that was like the first time that it was not related to my current pregnancy. And I had so much pain. I was going into shallow breathing. And so she kind of had to hang, onto that area for a good amount of time and then worked that whole area out for me. I couldn't even do wigwags that first time. She just kind of had to like talk nice to me and just allow that tissue to melt basically and to just get the appropriate blood flow. And so after a little while, it felt so much better. But I just wanted to tell you that in case you get that response from a patient so that you're not like, oh man, I broke my patient or something else is going on. Stick with the plan to help do a little bit of a release there. But if your patient is having, a really, really, hard time with it, maybe lay off a teeny tiny bit and explain that this may be something that they feel during treatment so that they're not like freaking out. Okay. I knew that that was something that I could possibly feel. So I was like, all right, I'm here for it. This was what I was trying to avoid actually, but, I definitely needed it and I was very appreciative and I did not kick her. So anyway, this is, like I said, the assessment. And as you're assessing, you can also, treat. So be someone who explains this well to your patient. Okay. And if I move forward, okay. So, the video, I'm going to go ahead and post this in our, pelvicedu.com website so that you have access to these. If you didn't want to go through like the whole video again or like refer back, I'm trying to kind of clean it up a little bit. It does take some time because this isn't what I do. I love teaching, but it's not what I do for my main job. So it may take me a little time to upload this. But just to kind of recap, we will need to look at the diaphragm if we have somebody who is coming in with back pain, kind of unknown to them exactly where it starts, but it's a little bit more covering that thoracic spine. If you have tenderness in that lower thoracic spine with your passive intravertebral movement assessment, if they are having some difficulty with like just proper rib expansion, have some respiratory issues, have some like history of stress, definitely are having some like maybe a little bit of a shoulder referral. And again, if they're having some pelvic floor issues in general. Okay, so you've got the video here, and I hope that you can start using this right away in clinic as soon as possible. If you have any questions, or if you'd like any additional support, please send me an email. This is my direct email. I check it all the time. I'm pretty good about answering my emails. You can also go on to pelvicedu.com. I am uploading these videos and like the Pelvic Grand Rounds live videos, plus the home exercise, the videos of the treatments, so that you may use them as home exercise. Ugh, it's hard. It's hard to talk sometimes. So that you can send them to your patients if you felt like, hey, this is something that is useful for me. We already used it in clinic, but I don't want to make the video myself. Okay, so I've got like a million years worth of videos and home exercises in general. And also so that you can check out our other offerings. I do provide some mentorship support for therapists that are a little bit newer to pelvic health, and for students that are kind of, toying with the idea of specializing in this right off the bat. I think that it is a great, great specialty. I feel like more people should do it, more therapists should do it, PTs, OTs, because it is so necessary, and it is such a large part of our body and our health system in general. And so I provide some mentorship support. We do have some memberships as well, if you wanted to just kind of like really dive deeper into pelvic health and needed somebody to kind of be around more consistently. A lot of our mentors, they're scattered all over the place. You may not ever be with another PT that practices pelvic floor therapy, or another OT that practices pelvic floor therapy. So you're kind of like learning as you go through continuing education, and you may not have somebody to practice with or to kind of bounce ideas off of. So that is something that I do provide. So if you look on the website, there's a little bit more information about that. And also, I misspelled bootcamped. So pelvic floor bootcamp for clinicians. And this is something that I've got going on online. It is live classes just like this, but they are exercise classes. So this is something that I provide to, or that I have available, not I provide it, I have it available to patients, clients, whoever is interested. These are general classes, so this isn't a like skilled, okay, very important that we know that as PTs, this isn't what would be considered a skilled service. This is more for general exercise, activation, and information. And what better way for clinicians or students to learn how to perform certain therapeutic exercises, therapeutic activities, and neuromuscular, re-education activities than to actually do them themselves and know exactly what it's supposed to feel like, so that you can properly tell your patients how to do their exercises. So I've got a membership on there as well. If you look under pelvicedu.com, there's a little bit more information about that as well. So anyway, I think that that's all I've got for you today. Please stay tuned for our next round, which will be not this week, but the following week. We will complete our series of Is It Ortho or Is It Pelvic? All right. Thank you so much for tuning in. I really appreciate your time and your patience with my lack of technology skills. Have a wonderful